I hope you all enjoyed our discussion so far today. I know the last panel inspired me to go home and start teaching the scientific method to my toddler. Maybe some of the concepts will hit home. We'll see. As long as it's sung to Baby Shark, I think he can get it. So I appreciate y'all coming back. I hope you had a chance to rest up and connect a little bit more. As we come back together, it's time for our final panel of the day, one that gets to the heart of public health trust. We've talked about it, I think, throughout the morning already and hinted at it. We've talked about transmission and technology, but none of that really matters if people don't have confidence in the systems, the science, and the people leading the work. And we all know at this moment in time, building and sustaining trust is more critical than ever. This panel will take on that challenge, exploring how we can strengthen trust so that preparedness efforts truly connect with and serve our communities. And guiding this important discussion is our moderator, Jennifer Deegan. Ms. Deegan is Vice President of Health Policy and Systems Strategy at UTHealth Houston and a member of the Strategic Leadership Team for TEPHI. She previously spent 15 years with the Texas Legislature, working in both the House and Senate on health policy and budget. She holds a master's in public affairs from the University of Texas at Austin. Ms. Deegan also plays a leadership role in TEPHI's wastewater monitoring program that you all heard a fair amount about in the last panel discussion and that have the dashboard set up outside. And she collaborates closely with state and local stakeholders as chair of TEPHI's Action Working Group that is part of that wastewater work. She is co-principal investigator on an NIH grant focused on the ethical dissemination of community-level wastewater findings, co-author on numerous publications on wastewater surveillance for preparedness, and a frequent presenter at conferences across Texas and the U.S. Please join me in welcoming our moderator and our panelists in this timely and vital discussion. Jennifer Deegan.
Thank you, Leah. And can everyone hear me? Thank you for sticking around till the bitter end today for the last panel. And I'll take that. Panel 3, I hope you are ready, because not only do we follow 2 very dynamic and engaging panels, but as I was kind of jotting down notes, I noticed about a quarter of the questions that came to the other 2 panels could also come to this group pretty appropriately. So it seems like there's a fair amount of interest in this topic, which makes sense. It's an important one. Before I kind of set the stage, I was going to ask our panelists today to introduce themselves. We have a diverse range of experiences and expertise up here, so I'm excited to allow my fellow panelists to introduce themselves. And I'll start with Dr. Plasencia.
It's on. Good afternoon. I think you know me by now. I was a public health service officer for 20 years, a family doc. And then after I retired from there, I worked for the VA and I worked with Caris Health. And then I took the position of regional medical director for this region of the state. And had a great time and worked with some really wonderful folks who are here. And I miss you because I'm retired now.
Thanks, Doc.
Good morning, good afternoon, I should say. I'm glad to be here. My name is Barb Petersen. You read in the bio that I'm a veterinarian, but I'm really proud to say that I work in the environment. I work for the cows that I care for, but I work for the people. So I work in the Panhandle of Texas, own a practice that takes care of dairies and feed yards. And they are large enough that, you know, my primary focus is on those caring for the cattle and the calves. So thanks for having me today, and I look forward to the panel.
Good afternoon. I'm Katherine Wells. I am the director of Lubbock Public Health in West Texas. I've been the director of public health there for 10 years. Prior to that, I spent 14 years at the Department of State Health Services, working both at the regional office and out in Region 1. So I definitely see myself as a local public health practitioner. And I think I'm one of the, I know there's a lot of people from Houston and Harris County, but I don't think we have much representation from local public health departments. So excited to tell you our story.
Hi, everyone. My name is Cason Schmit. I'm an associate professor at the Texas A&M School of Public Health. I'm a lawyer by training. Any other lawyers out there? Yeah. A lot of my work focuses on law as a structural determinant of health. And within the bounds of that, I look at health data and how data are used both specifically and broadly to affect public health. I was recently appointed to the National Committee on Vital and Health Statistics, but I don't know if that committee exists anymore. So if you do know, please tell me. Very excited to be here.
Thank you all. And I think, as you can tell, the diverse range of experience up here is really exciting. And all of you have been involved in the trenches recently in some very interesting public health challenges. Before I dive into the questions today, just kind of wanted to talk a little bit about the importance of this topic, which I think we all know. And this is not going to be new to any of you, but at the beginning of this year, the Kaiser Family Foundation released some new survey results that showed a continued erosion of public trust in health information from public health officials. That erosion began during the COVID-19 pandemic, but it continues on the same trajectory. Trust and guidance from the FDA, CDC, local and public health officials, scientists at the NIH, and even in physicians, and I say even not because physicians are the most important, member of that group, but because historically trust in one's personal physician has been significantly higher than other entities, but those have all declined rapidly. And this is happening at a time when public health threats are continuing to be an ever-present condition in our lives and continue to be important, whether they're from infectious diseases, as we heard today, from diseases that affect animals and potentially affect our food supply, natural disasters, and even bioterrorism. Those all continue to be important considerations. And then in this challenging environment, you all are tasked with continuing to do the business of ensuring public health in these conditions. And that work, as Dr. Shetty said earlier, has never been more critical. But your ability to do your job well sometimes depends on things that feel out of your control and sometimes are out of your control, and relies heavily on public support for what you're doing. So whether it's securing adequate funding or recruiting and retaining talent, or whether it's ensuring that the public you serve follows evidence-based guidance, all of that depends on having a good foundation of trust and having relationships with the people we serve. So when I looked at the list of questions that were submitted, and, again, listened earlier to the earlier panels and questions on this topic, and then looked at the submissions with registration, there were so many, we will never have time to address them all in 90 minutes. But I want to get to the meat of the discussion. I'm going to start with an open-ended question for this group and talk a little bit about some of the most pressing ethical challenges in this domain. And I feel like this is important because I think, as the last panel alluded to, we often see, in a time of rapidly advancing technology and science, we see the science and the technology and the excitement getting ahead of some of the key ethical considerations and conversations we need to be having, and that can further deteriorate and erode trust in the work that we're doing. So I wanted to ask this group, from your various perspectives, what you view to be some of the most, and you can kind of pick however many you'd like to talk about, pressing ethical challenges that the public health field must confront in the next 5 to 10 years to maintain or rebuild public trust. And I don't know if there's a volunteer to start first, or I might kick it to Professor Cason, if that's okay. So you mentioned ethics in your...
Oh, here we go. So there's a lot I could talk about. I think it's important to acknowledge the infodemic that we are currently in. And that's not a term that I have coined, but it's one I will adopt here. And generally what I mean by that is just the vast amounts of misinformation and disinformation that exists. Some of it is unintentional, some of it seems targeted. And this is both ethical and legal. How do we deal with this volume of information out there while simultaneously understanding, as we're often limited by First Amendment freedoms of speech? It's a very difficult problem to try to address. And I know that a lot of public health attorneys are thinking very carefully about this and creatively about this. But within this environment, I think one of the things that we need to do is rebuild public trust in the evidence-based advisory bodies, so that we can start relying on their guidance for evidence-based policies, interventions, and otherwise government guidance. The other thing I will mention that's slightly different, and I'm sure I'll talk more about this later, but I think we need to figure out how we can free data for public health while simultaneously restricting the non-public health or research uses of those data. That's also a very tricky problem.
I can add kind of from the perspective of a local health department director. When we look at ethics, it's really about, balancing that need to know about an individual patient or, what happened to somebody, that disease against what is needed in the community to protect health. So how much information is needed? I was on the front lines of the measles outbreak in West Texas. It wasn't in my county, but they were in my hospitals, and both children that passed in my county. And a lot of the ethical discussions we had during that time was, how do you make those announcements? How do you not overreact? How do you have a conversation about somebody's child that died from a preventable disease? So balancing both their confidentiality, that family's privacy, but also answering to the media. And I don't have a good answer on where that line is, but it's definitely a challenge and something that we face at local public health every day for lots of different diseases.
So thinking about ethics, I always think about the vet oath. And I would love to tell a really quick story because I think this illustrates how ethics can be a challenge in the field, and how an example of what was one small problem kind of blew up into something huge. So in the spring of last year, there were a bunch of cattle in our area that got sick. There were sick pets, there were sick and dying cats. And on the farms I work on, there are sick people. And I took an oath when I graduated from veterinary school about protecting public health. And it's something I take very seriously. So I always think about, what are the ethics of our profession? How do we uphold them? How do we support others in doing that? Because it was just a total, I want to say a bad word. It was a total poop show. Total poop show. Yeah, it's the afternoon. We can laugh about this. It was a total poop show. So the question then becomes, how we are in a post-COVID world. We have this like crazy COVID hangover. What are we going to do differently next time? Because this is done and dusted now with avian influenza. At least that's what, if you ask my clients, that's what they would say. They would say Men in Black came and blinked us and nothing ever happened. But we really do. We have to have this conversation about, how do we as a profession, as veterinarians and as public health advocates, what does this look like going forward? So that's, I guess, what I think about when I think about ethics.
Yeah, that was very, very well said. I think for most ethics questions, we have committees, we have discussions, and ultimately we arrive at some kind of consensus. Where I think the rubber meets the road for us is personal ethics. And that was very well said. Personal ethics may involve, are you going to do what you're being asked to do? Or have you reached a line you're not going to cross? And that's a very real issue. in our nation today. The second thing is a personal issue, ethics, almost on a spiritual level, like when the person is obviously negative and antagonistic, can you let go? Can you sort of remove yourself from that situation and allow a personal ethic to take over and say, this isn't about me. There's something going on. And can you say, help me understand what you mean, so that you build bridges rather than, continue to build the walls.
Those are great and challenging. I should have prefaced all of this by saying I don't think we're going to find the answer, the great solution to any of these questions today, but I think talking through them and learning from experiences is insightful and helpful. And all of you have had experience in this area, whether it is responding to some of the events, H5N1 outbreak or the measles outbreak or COVID and natural disasters. And one thing we know and have seen is that you can't treat a public health response uniformly. You have different populations who are affected in very different ways. And so my first question, I'm going to start with Dr. Plasencia, but please feel free to add on to his comments and just ask you, based on your experiences, if you can talk about some lessons learned or special considerations that are needed to ensure trust in public health efforts among historically underserved populations. If there are any enlightening points you could share with the group on that.
Two come to mind. First is, I'm a doc and I have a patient in a room, and how many times do I forget to just use plain English and just talk like a person instead of automatically going into that medicalese that people look at you and they don't know what you're saying. So learning how to talk openly in plain English in ways that people can understand and relate to you is really, I think, an important step. And then the second one is really critical. For vulnerable populations, you got to find people they can relate to. And that it means that you're going to do several things. You're going to invest in community health workers. You're going to find Indigenous people who are willing to help you and carry the message. It means that, for example, you may not be the best person in the classroom to teach the kids, but you can certainly develop lesson plans and materials for the teacher to utilize in the classroom. So I would say beware our narcissism of being always in charge and thinking we can deliver this lesson best. Why don't you let them speak to each other and just facilitate the learning process in the community and let it spread that way?
I think that kind of coalesces with what we heard earlier about meeting people where they are, right? Any other thoughts to add to that?
Yeah, I would echo what Dr. Plasencia just shared. If you think about the area that I live and work in, we're both pretty rural, right? So we're draw a circle around Amarillo that's 200 miles wide, and that's where I work. And a lot of people that I work with would be by definition in a population of people at risk. A lot of them are working 6 days a week. They either don't have time to go to seek medical care, they don't have access. And I got to give a shout out to Texas DSHS, because y'all came and met us where we were. You came to Dumas, you did pop-ups. I'm at such and such location, because they were really good about not giving away a location where we were, where the farm was. Okay, I have X persons who would like to get tested. Here's where we are. Can you meet us? And they made every effort to meet us where we were. So thank you for that. That means everything to us.
Transparency, I think, is a point just to absolutely underline. Extending that, make sure that your relationship has reciprocity, that we're not just going into these communities and taking from them. We're not taking their data, but we're also, it's a reciprocal relationship. right? We're providing something back. And this is something that I think should be fairly obvious, but when it comes to trust, and you're working with these vulnerable communities, if you say you're gonna do something, do it, right? A lot of these communities get burned over and over and over again. You say you're gonna do something, do it.
All right, so I actually want to piggyback on that a little bit, and this question is for you, Dr. Petersen, but want to talk a little bit more about H5N1 and that experience, because I think it highlights one of those issues where you have different groups who are affected differently by something. And if we go back to March of 2024, we see something we've never seen before. We see this highly pathogenic flu, avian flu, that is all of a sudden infecting cattle. Veterinarians start to see and clinicians start to see people getting sick who are working with those cattle. And we don't really know how widespread it is, whether it's, going from person to person. You have, and I don't mean to minimize this at all. You have very big potential economic impacts. You have people whose livelihoods are at stake. You have vulnerable agricultural workers, and you have a potential threat to the public. So thinking back on that, I wonder if you could offer us some thoughts on building and maintaining trust among stakeholders who maybe have competing priorities or are focusing in on different aspects of a public health challenge.
Sure. So thanks for the question. Full disclosure, I'm a middle child. So I'm like the bridge. I've always thought of myself as the bridge between siblings, my parents, relationships. And so I just see myself in my role as the bridge. And so when I think about that time, I've got owners who are scared. We legit, I say we, my owners and I, farm owners, thought we were going to lose our market for milk. Like we wouldn't be able to sell milk, or we wouldn't be able to sell an animal to slaughter. So they're up here, they're on high alert. So they're in denial. So stages of grief, right? That's the point of this story, is stages of grief. Everyone's in different stages of grief. I have no idea any given day where anyone is in their journey of grief. And sadly, I was met with a lot of anger, not just me. There are probably a dozen of us out there every single day, pounding the pavement, going to our farms, checking on cows, treating sick cows, checking on people. Humans have these eyes that look like they're about to bleed. And we don't know what is wrong at that moment. We don't know what's wrong. We just suspect that all of these things are related. So it's battling the unknown in your mind. Like Dr. Plasencia said, we just have to put aside, there's things we don't know. If I don't have trust with the folks I take care of, I have nothing. So just like was said, if you say you're going to do something, do it. Be there for them, answer their questions, update them, text. You're going to be texting at all hours of the day and drinking Dunkin' Donuts coffee like it's your job. Like that's what it is. I would go to 3 or 4 farms a day, visit, check on people, try to help folks get care if they wanted to get tested or get cared for. That's just kind of in a nutshell what it looked like initially. And so then unfortunately, on the back half of it, the anger was met. We were met in the field with anger by folks that were worried about the risk to their business, or the risk to their employees, or the risk of me saying something publicly about it. I mean, I got fired by a dairy client for doing an interview with Bovine Veterinarian of all magazines. Like, this is a magazine for vets. Why do you care? Oh, I didn't even know you read it, but you do. And he saw it and he said, "Why are you talking to the press about this?" And I said, "Well, because someone needs to learn from what we're going through, and why not? Why can't it be our colleagues?" And he's like, this relationship is over. So I think the other side of the coin is recognizing that there's risk, and you may not even know what that is at the time. So my thing has always been, here's my compass. My clients know where my compass is, and we're going to maybe have some disagreements about that are pretty big. But the lesson learned here is what are we going to learn from what happened? What are we going to learn? And the question to ask is to have a debrief about it. So this is very helpful because I feel like this is the opportunity to have at least like a mini debrief.
And I'm really glad we've had a veterinarian on all 3 of these panels, because I think it is a really important and different perspective. From a public health response perspective, Dr. Wells or Dr. Plasencia, do you have anything to add to that? Just dealing with competing interests or maybe deep health misgivings, and how you've dealt with that in your experiences?
You want to go, sir? Or you want me?
No, seems like everything's happened in West Texas in the last 2 years. You know, I think what happened with the outbreak in cows really highlights this true need to really have, this, One Health model. And I think we were talking about this beforehand, that I think on the ground, we're having conversations between veterinarians and public health. But I really think we need to work on at the leadership level, especially in Texas, where so much of what we're seeing is between the animal community and the human community. Really start having, high level conversations about how do we navigate through these very challenging times when we have an outbreak that's affecting both humans and animals.
Anyone else like to add to that? Okay, all of these questions kind of, it's funny, your responses lead right to the next one. And so I was gonna go into measles next and talk about that a little bit. There's been a lot of conversation about that. We heard today that while the outbreak is officially, we're not in outbreak mode, the threat is still very real with immunization levels declining, and we're likely, and we have some vulnerable populations, we're likely to see it again. I'm wondering if there are any lessons learned, Dr. Wells, from your response, and I know you were Gaines County particularly, but in Lubbock, you were very close to it. If you encountered any surprises or learned any lessons that might be helpful to some of our other local public health responders in the audience.
I mean, I think that surprises is a very loaded question. We had so many surprises and changes. I don't know if anybody paid attention to the slide that Dr. Shetty showed today about that slide of the epi curve for measles. The onset date of that child's first rash was January 20th. What else happened on January 20th? Anyone remember? We had a change of administration at the federal level. So we were facing this measles outbreak, or the beginning of public health's knowledge of this measles outbreak, as the rules for public health were changing. The things that I had depended on as a local health department director didn't exist. As were changing, or people were scared to talk, and politics became so influential in what was happening with public health. If you want to take a dive into what was going on, there's a really informative article that came out about 2 or 3 weeks ago, published by the Kaiser Family Foundation by Amy Maxim, and she actually did an open records request of all of my emails. So it's a good lesson. Don't put anything in email that you don't want on national news, but it really does talk about some of the challenges in the early days of that outbreak. In addition to just the politics going on, the media coverage of the outbreak was insane. I'm a member of NACHO. I'm on the NACHO board, National Association of City and County Health Officials. They actually did a media report of my media reach, and I had 22,000 mentions, unique mentions of my name across the world. We had ABC, NBC Morning News, nationally broadcasting from the health department. I had London Times came and visited me in West Texas. I talked to the Japanese media. So everybody wanted to know about what was going on in the area. And then the other challenges that we faced were really working with a very close-knit insular community that doesn't necessarily like government interaction. That's part of the reason why they had moved to Gaines County in the 1970s, was to remain this insular group. And a lot of their privacy was really invaded throughout this outbreak. The media were I ran into some very horrible media individuals. I mean, people climbing fences of the funeral home, trying to take pictures. I mean, that kind of people in people's faces when public health was trying to test them or trying to give vaccines. So we did break a lot of trust with a community that we already had a hard time trusting. And then another real challenge with this outbreak was how multi-jurisdictional it was. Within the first week, we had 3 separate local public health departments involved, 2 regions and 2 states. So early on, we had to really create a really strong incident command structure to deal with this outbreak. Gaines County is 70 miles away from my community, but all of the children came to our hospitals. So I was having exposures in hospitals while Gaines County was dealing with the brunt of the outbreak and then needed all of the help for epi contact tracing. Just so many different things happened during that outbreak. Definitely provide some more stories as we go on, but lots of lessons learned, lots of challenges.
You get the fallout, right?
Yes.
We heard a little bit about media today.
Yes.
Educating the media. So thinking back, I guess, well, and before I move on, did anyone else have anything to add on to that? I didn't give you that. We heard in the last panel about, again, the technological advances that we've touched. We've heard about sequencing and metagenomics, both in clinical and wastewater surveillance. We experienced and watched during the COVID-19 pandemic how different countries handled, how they employed different kinds of mitigation strategies that frankly would not probably be acceptable in the United States, and we see cultural differences there. So in this era of increasingly sophisticated tools, I'm wondering how we can balance the need for a rapid outbreak response with the protection of civil liberties and individual data privacy. And I'm going to start with Professor Cason on that one.
Here we go. So in recognition that I'm about to say a bunch of crazy things, I feel like it's important to level set here. In all my work, CSTE, state EPIs, providing consultation on policies related to surveillance, I have uniformly found that public health data custodians are zealous protectors of their data. They zealously protect the privacy of their data. And I wish that everybody who's concerned about the privacy of their data that goes to public health understood how much you care about what happens with that data. But my use of the term zealous is a loaded one. In law, we have an ethical duty to be zealous advocates for our clients. But we can get into ethical trouble if we overzealously advocate for our clients. And I think the same is true for public health. When we are overzealous in our protection of the data that we have, that we collected for public health purposes, in ways that doesn't allow those data to be shared, to be used for various public health purposes, I think we get ourselves into a bit of trouble. I think it's important to remember that part of the definition of public health surveillance is giving the data back, giving it to the leaders, the decision makers, and the communities that need that data to respond to whatever the data says, whatever public health threats are there. And so if we're not doing that, then we're getting ourselves into a bit of trouble. Now, just as there is a right to privacy, right? This right to be let alone, there is also an individual and a community right to be counted. Counting individuals and communities informs resource allocations. And unequal counting of individuals and communities results in unjust allocation of resources. So when, in the name of privacy, we de-identify, suppress, or otherwise hide data, we are often, not always, but often also hiding the health threats that face those individuals and those communities. And when we hide the health threats that are facing vulnerable communities, we are denying those communities the information that they need to advocate for change for themselves, right? It's important information in this democratic system. So we need to think very carefully about the competing interests of individual privacy. It's important, but also these individual interests in being seen in the data. That information is empowering to those individuals in those communities, and it's their right to have. Now, let's get into individual civil liberties. I'll start with a joke. So a doctor, a priest, and a lawyer walk into a bar. Okay, in this panel on trust, I just lied to you. It's not really a joke, but let's talk about doctors, priests, and lawyers, right? All three of these professions have something in common. The law recognizes a legally enforceable duty of confidentiality on each one of these professions. Doctors protect data on their patients. Religious leaders protect the data or the information that's shared by their congregants. And lawyers protect the information from their clients. The law recognizes this duty of confidentiality because it recognizes that when individuals need help, they need to be able to provide candid and honest information to those that are going to give them that help. The same is true for public health. The same is true for public health. There is a social contract, right? That individuals are willing to give up their information, and they are. But they need to be assured that the information that they share is not going to be used to harm them. So this is essentially what the WHO ethical guidelines on public health surveillance say, that when you collect information, when you collect public health surveillance data, you should not share those data with agencies or entities that are going to take action against individuals. Every time that we betray this principle, and there are examples of this internationally and locally, the result is that people lie. People lie or they don't show up. And if people lie and they don't show up, what happens? Well, the data sets that we rely on to make decisions become biased, right? And so we can no longer trust all of the decisions that we make based on the inaccuracies within the data, right? So the grand solution that I offer you, right? So when balancing individual interests, privacy rights with the collective goods, the social benefits that we expect from public health uses of data, it really requires accountable and transparent good governance of the data. Good stewardship includes things like security, right? But all of this has to be grounded in fiduciary confidentiality. Now, what do I mean by that? I mean that we are protecting and using data only for the benefit of those data subjects, right? I think that's essential. And that's the grand solution I'll offer you in very abstract terms.
So from on the ground, what does that look like? Dr. Plasencia, you like you're gonna add something to that?
I don't think I can add to that. That was really good. What I wanted to do was just point out that, and I'm honored to have worked with some really excellent people or local health authorities. And that's exactly what a local health authority is empowered to do, is to take your rights away. And none of them take it lightly. I have acted as a local health authority, and you can trust me, I'll take the extra mile to make sure that I don't have to take you to court. I will do everything I can. I will look for ways to meet you halfway or to empower you, but just understand that the community has to be kept safe. That's the other thing I need to do. And I have helped a lot of local health authorities in some really difficult situations where an individual is putting others at tremendous risk. We're talking a risk that could result in death, right? Not just you're going to get sick. No, you could die. And I don't know any local health authority who takes that duty lightly. They take it seriously, and they will work with the person to make sure that the taking away their civil rights is the last resort.
I'm going to pivot away for just a minute, ask one last question before, and then see if there are questions from the audience or the online audience. But I think the question we received the most thus far has been about misinformation, and it's been talked about earlier today. And what we've seen, and we've talked about TikTok and YouTube and whatnot, is that misinformation often spreads faster than facts. And there was conversation earlier about the need to build communication skills among scientists and among the public health profession. But I'm wondering, how can we, as a scientific community, as public health first responders, help the public differentiate between accurate and evidence-based information and likely misinformation? And just if there are any strategies any of you have encountered that you found particularly effective or ineffective, because sometimes learning from the negative is just as important.
I can
You wanna
start. Sure, I can start. So first of all, start making your own memes. I like to make memes because it lightens the situation significantly. So that would be a tip. But really, something that I think that could help is I have been asked and have joined a group called Migrant Clinicians Health Network. So that, of course, is a group that's on the ground advocating for folks that are underserved, underrepresented, and just an opportunity to think about, how do we reach people where they are? How do we start where we are? How do we do what we can with the people that we already have an existing relationship with? Because as much as I love your local epidemiologist. I follow it. I love it. I don't have the bandwidth to do that. So I respect that others do. But I just always think about locally, what can we do in our own backyards? And MCN is one of those things. So, and I will add to Dr. Wells, if you want your emails to be, or your emails are going to be foilable no matter what, but if you want information to be shared that way, I think I had to create 3 different email addresses because my emails kept getting blocked by USDA. There was such a challenge in, we didn't have an incident commander in our situation. And so asking our state health officials didn't get a ton of traction. So then you just elevate it and you elevate it and you elevate it. So I hope someday all those emails come out from all my different email addresses.
Have you really created memes? Are they?
Oh, yes. Yeah, they are shared. Yes, I have created memes. They are shareable. They are shareable. Fire with fire.
Other thoughts on
I can-
misinformation?
Add a couple of things. I think first is, public health has to get out of the office and engage with our community. So many of us, hide behind our computers and our data and don't want to engage with those reporters and community leaders and being honest and open about what's going on. The measles outbreak was really challenging, but there was also a huge communication void from leadership. There was not one national press conference that talked about our measles outbreak. I mean, there were quotes from leaders in cabinet meetings about the measles outbreak, but there was never a unified stand up with CDC officials, state, local leaders, the mayor saying this is an issue, community, we need to come together and control this outbreak. And I think when we don't do that, we allow alternative narratives to come in and take the place of what public health should be saying. I also think we really need to go in and understand the values of the communities that we're working in and change our messaging based on what that community needs. When we were working in some of the communities in West Texas that are under vaccinated, the message about getting vaccine isn't going to work. It's going to fall on deaf ears. They've already said they don't want to get vaccinated. So we have to pivot and talk about what are severe signs and symptoms of measles? When do you need to seek health care? The importance of keeping your children hydrated, what medications work, even though we were probably saying Tylenol, but what medications work, you know, to control fevers. And then the other thing we need to do is public health, we tend to be perfectionists, and we often let the perfection of having the perfect data or the perfect message stop us from showing our human side and talking to the community. So, you know, it's important that when we have that preliminary data that we're sharing it with our partners, maybe not the media yet, but talking and sharing that information with everybody.
Is there a value in, as you were talking, I was thinking about letting the perfect be the enemy of the good. And sometimes you want everyone to follow all the evidence-based guidelines, but is there a value in providing kind of a menu of options for people in terms of how they might respond to
I mean, we need to. And one of the things when they said, you know, when people ask, you know, what stopped the measles outbreak? And it was a combination of people seeking vaccine, which is what we in public health want to have happen. But it was also education to the community about how infectious measles was. And over time, we were seeing fewer people entering like healthcare facilities with active measles. People were paying attention and calling ahead. So some of that messaging, you know, really did work. And then there was also natural immunity from, you know, after you have so many cases, you really start to build that. But there was, you know, some messaging that could get to the community that was different than just vaccinate, vaccinate, vaccinate. And I think especially where we're seeing all of this rhetoric against vaccines, we also need to talk to people about, you know, what those alternatives could be.
Thank you.
So this is a problem not just for public health. It's a problem in climate science and all kinds of fields. And it's a new challenge as our civilization evolves. And so that has to be a skill that needs to be taught from kindergarten. How do you tell truth from lies? It's a basic skill. However, in public health, I like the idea I heard earlier. We don't have time to develop a crafted response. Thank you, Dr. Martinez. So we have to embrace the new technologies that are out there, specifically AI. And I like the idea of a true AI, where there is a place people can go to where the AI has information that is valid. Unfortunately, a lot of our AI captures all information, even the bad one. And sometimes the bad ones are the ones that get replicated. And the AI thinks that that's better information because there's more different outlets that are posting it, when actually that's the bad information. So AI is only as good as what you give it to work with. But hey, that's something we can do. We can build it together. And we just have to collaborate. And in that sense, my last statement is I can't wait for the younger generation to take over, because you guys are not afraid of technology and you will use it. Our generation is still grappling with whether we should allow AI at the workplace.
I'd like to turn it over now to the audience. I know there are probably questions out there.
A question for Dr. Petersen. I was amazed when we first were seeing H5 in wastewater. Everybody seemed to know all about it, where it was coming from, where it was going, how it got in the cows, blah, blah, blah. I seem to be the only one really confused. So my question, I have two questions really. One is, since we saw it go up and now go down, why do you think it's gone down? Is it changes in herd management or changes in product management, so it's not getting into the urban wastewater system? Then my next question is, as we've had our first cold front, Yahoo, is now that, sort of waterfowl and small, songbird migration, do you think both the agricultural infrastructure and the public health infrastructure is now better poised to monitor and manage the situation of H5N1?
Well, thank you for both the questions. I want to make sure I answer both of them. So the first question is essentially why now is the wastewater surveillance showing that there's decreased basically H5 in the wastewater? What management practices have maybe led to that? Well, in our area specifically, it is just that all the cattle have been exposed. So there aren't, unless you bring naive animals in, then we likely aren't going to see, I hope we don't see a recrudescence. I don't know if we will or not. I have some herds that we followed antibodies over time and their course has been decay. We also shouldn't make the assumption that antibodies would be protective long-term. So the other thing that I think is really important is in cattle, the clinical outcome is much different than it is in poultry, significantly different. It is game over in a poultry operation. For us, it is not game over, but it's severe, but it has a different consequence. So I just think it's back to something that Cason touched on. It's so important for us to have some level of transparency on geographically, where is this? So wastewater has been an excellent tool. And we use that now for wastewater following, milk processing as an example. There's also a national milk testing strategy that's nationwide. Every state collects it either at the farm or they collect it at the processing plant to get an idea of what's happening. But just a few weeks ago, cattle were shipped from California to Nebraska and they either weren't tested or I don't know the whole story, but naive cattle in Nebraska got exposed and are now sick. So I actually don't know anymore that this has anything to do with migratory birds. We hypothesize that that's how it started, but now I don't know that we know that it could change as birds migrate. I think that's a great question and we'd all love to know the answer to that question right now. So I hope that answers your question. Mm-hmm.
We're good at raising questions with no answers on this panel. Other questions?
Hi. I guess more of a comment than a question, but I had the privilege of kind of joining the bioinformatics space right during the pandemic, right in its somewhat wild westy phase in which tons of platforms and tools were showing up all over the place. And it was developing extremely quickly to catch up with COVID, which seemed like it was changing all the time. But the thing that I felt like helped it move forward especially fast was the fact that all the really successful ones, and indeed the ones you still see today, are for the most part the ones that adopted an open source type of ideology, where even the parts of it that feel like they could have been proprietary or used for some kind of gain that way, the emphasis was always to share the tools and to make them more approachable. UI elements, buttons instead of hard coding, things like that tried to make it more approachable ended up being more popular even than tools that had more capability right off the bat. And I throughout my entire career in public health so far, definitely we've run into so many situations where it feels like that model should have been adopted, but whether it be competition between academic institutions or, corporations or whatever have you, that has become a consistent block as far as sharing information goes, that goes beyond something like a legal problem with like a HIPAA violation, but people just wanting to protect their sequencing data so that they can get their paper or what have you. But definitely, I think the lesson is to take from that bioinformatics evolution that happened so quickly is that when you do have that environment where you can find a way to share that resources, and indeed it was a global push that just developed so quickly and was a huge part of the success there. Thank you.
It's a really interesting comment. Thanks. And kind of underscores your comments about transparency in a different context, but
Yeah, and I'll just add one thing to that, because I think it's a very good comment. I think there's something really wonderful about communities of practice. So for instance, the National Syndromic Surveillance Program has this fairly lively community of practice where they share insights that they've learned on the ground. They'll share new, techniques and new applications of what is otherwise a quite versatile system that, I think has a lot of potential that is still being actively explored. And so, in addition to sharing, the tools itself, but I think disseminating knowledge, I'm in the ivory tower. We disseminate through, peer-reviewed publications. That takes too long. But in public health, if you have a good, healthy community of practice where you're able to share what you were learning and new things with your partners across the country, I think that is just tremendously beneficial as well.
do you think some of that also could help with the public support for some of these tools in terms of if you can kind of see behind the black box, how it's working, how it's being used? Or do you think that it's something that is more important for the practitioners or the folks who are utilizing the tools?
I do think that helps. Certainly the community practice is fairly open. You can see what's being discussed. It's not necessarily easy to find everything that you're looking for. And when it's not easy to find what you're looking for, sometimes you make conclusions that aren't correct. But yeah.
And yes.
Mic check. Hello, hi, my name's Andrew. I am a student at the University of Texas Medical Branch in Galveston. So I think this summit is pretty timely. So just for some context, this past summer, me and some of my colleagues did a hypothetical project on what happened in Gaines County during the measles outbreak. We developed a kind of a hypothetical intervention of the impact of a community-based intervention on parental knowledge, attitudes, and vaccine uptake during the measles outbreak. So it was pretty cool because we used Texas Department of State Health's website, some of their data to help to facilitate our project. But one of the aspects that we focused on is this matter of religious communities, siloed communities within Gaines County. So kind of my question is a little bit more geared for Dr. Wells. But my question is, what's been y'all's experience in your collaboration with Gaines County and as a local health department, and engaging with some of these more siloed communities, maybe some of these more some religious communities that have high distrust in governmental regulations. And to put it, I guess, into some more context, some might be aware that there was an article, I think it was by the Texas Tribune, of a pastor in Gaines County. He was interviewed and he said that unfortunately he didn't give his congregation any specific tips on how to deal with the measles outbreak because he left it mainly in the hands of the family to make that choice. And he said that because that was primarily a key tenet for that religion's faith. And so, of course, in public health, we have to deal with this dichotomy, right, of personal autonomy and choices, while also doing our best to do what's good for the public. So yeah, what was your experience as a local health department in dealing or engaging with those kind of communities? And what were you able to learn from that, whether it was a success or not a success?
So many things I could say. I think I'll start with kind of the idea about, those trusted leaders and, utilizing that for vaccine uptake and other health information. Pastors are one of the key individuals that can help push or help encourage vaccination and also provide that information. There was a lot of hesitancy to provide that information from the churches. I also think another great leader for vaccine and vaccine uptake are our school superintendents. I've seen in school districts where that superintendent is very pro-vaccine, that we have very good uptake of vaccinations. And I think that comes to that philosophy flows down to the school nurses and how much that school will push information about required vaccines or recommended vaccines. And then, the third one's, our physicians in our community talking about that. And unfortunately, vaccines have become so polarized or so political. I mean, I've been talking to physicians and providers in our community, and they're now scared or hesitant themselves to be having conversations about vaccines because they don't want to lose their patients. And I'm afraid we're going to see the same thing with superintendents and church leaders. So I do worry that, there's going to be, we're going to slide back on vaccination rates because of what's happening politically, because we're going to lose the people on the ground that are going to promote that. As far as getting into those communities, it's really the manpower. I'm in an urban health department. I have, 55 staff. I know Houston has like 1,000 staff, so we're smaller, but Gaines County Health Department has 7 staff, and that includes the nurses that work their clinic, their health department director, their environmental inspectors. We have not made investments in local governmental public health in Texas to be able to have the community health workers that we need on the ground to be able to do that work. And it's going to take that investment. And at this point, I don't know where the money to do that investment is. We also need to invest. I mean, we have many, many counties in Texas that don't have a local public health department that are supported by our regions, but the regions are very limited in what they can provide. They're only getting money from the state. They're not pulling in money from billing insurance. They're not pulling in, foundational grants. So we have all these counties that aren't even building up a public health infrastructure. So we really need to rethink how we're funding public health in Texas, and really look at alternative ways so that we're not so dependent on the federal government to really keep this infrastructure going.
I just want to say, first of all, thank you for sharing.
Yeah.
And go UTMB. I live in Galveston. Did you turn that simulation into a poster?
No, got graded on it, but it was high.
Boy, I don't know about you guys, but wouldn't you like to see that as a poster presentation presented? Try TPHA or some other. I know UTMB has a strong public health department. You can work with them, hopefully.
I have a question. Thank you for that. Dr. Wells brought up the F word, which is funding, and but one of the questions, I wasn't going to ask it because it felt like a really hard one to answer, but I will throw it out there now because it's come up several times. And a piece of that is how to effectively message to leaders, whether they be local, state, federal, or the public, about the importance of public health. And I'm wondering if anyone has a thought on that, or if I should just move on because we got the question a lot, and if we knew the answer, we'd be doing it.
I mean, I think there's still a lot of support for public health. It's about, and there's money out there. It's getting some, we have to look to our healthcare system to see whether or not they're willing to fund public health. We have to look at our, foundations. We have to look other places. Like, we're in the process of, my idea is we're going to build a foundation for our local public health department to help support us through these times when, funding's very lean. But we also have to look at other models. I mean, in Washington State, they put a premium on, or a penny tax on some of the insurance bills. So is there a way to do, a fee that would help fund local public health? We just have to find different ways to do it.
I want to point out something that's kind of weird. And when it hit me, it kind of shocked me. But if we think about the history of public health and resistance to public health, we're in a really weird place right now. If you were to think about 20 years ago, right? Those, when we were start working on like anti-tobacco or, other sort of environmental sort of related public health, there were those out there that were saying, no, public health is infectious disease, and that's all public health is, right? And there's massive resistance to things like nutrition programs and those sorts of things. We're in a very weird situation right now where there seems to be more resistance on the infectious disease side and less resistance on food and environment. And by environment, I mean like walkable cities and exercise and things like that, behavioral interventions. And so one of the things I am wondering is, certainly there are some things that I think it's important to protect. Access to vaccines, we shouldn't cede ground there. But that doesn't mean we can't gain ground in some of these other areas where there's now all of a sudden less resistance to. And so when it comes to asking for funds for public health, I think there are opportunities to align with current administration priorities in ways that will advance public health and will move the line forward, even though we may be retreating in other areas. So it's just a thought. We're in a really weird position in terms of the pendulum of public health and political environment.
Agree with that. And Andrew, right? Thank you for sharing what you worked on, because I think it's critical just to think about it, think about all the outcomes that could happen, and then the realities of what actually does happen. And I'm thinking too, Dr. Wells just said, she said this to me. She's like, it would be such a nominal cost to have added public health potentially in Texas. But I think about this, the folks I work with, they seek healthcare in primarily in 3 different buckets: public health clinics, walk-in type clinics, and emergency rooms. And that's not necessarily how any of those were designed, but the folks that I work with, that's how they get healthcare. So I always think about, okay, the things that I have access to with insurance or whatever, they don't even have access to that. So I appreciate what you did, because it again highlights how do you reach a community that is underserved for a variety of reasons. So thank you.
I think we have some online questions, but before we get to those, there was one more question over here that I briefly cut off.
Okay, so my question is a follow-up to Dr. Schmidt's earlier manifesto, I think, on the fiduciary responsibilities of public health professionals when it comes, I think, specifically to individuals' data. And so, because I'm a wastewater environment guy, and I'm thinking about environmental samples that represent communities, or, we talked about from various veterinarians, right, talking about maybe these are someone's animals. And so how do those, and this could be a question for anyone, how do those responsibilities or obligations extend when you're not talking about individual level data or individual level care?
Great question. To the community, right? So this idea of, sort of fiduciary confidentiality has come up in among legal scholars seeking to fix the broken privacy framework for consumer data, right? In which they're trying to figure out how to protect people from the types of harms, because notice and consent isn't cutting it anymore. It's just it's not protecting people anymore the way it was intended to. And, one of these scholars, Jack Balkin, who's defending this approach to fiduciary confidentiality, he got asked the question very pointedly. He said, well, we've got most of these big companies that are collecting data. Well, how can you possibly be a fiduciary to all of these data subjects simultaneously? And this privacy scholar, who is not a public health person at all, said something very public healthy. And it says, at the point where the data represents a broader population, the fiduciary responsibility applies to the population. And it was such a wonderful moment where I feel like I, from the public health perspective, have been screaming this for a long time. You just heard me scream it. And then we got this other person, the scholar of consumer privacy, who was talking to industry, and we reached the same point. That when we're dealing with these population level data sets, we need to start thinking as fiduciaries of the population and looking out for the risks, not just of individuals, but the groups that they belong to. Because group harms are still harms, right? And I think often the discourse around protecting data focuses on individual harms and not as much on the harms to the very communities they belong to. So I'd say if you're looking at your wastewater data and you're thinking about the harms to those communities or the groups represented within those communities, I would say you're thinking in the right place.
Beth Ann, do we have some questions from the online community?
Yes, thank you so much. So there's been a lot of questions that have come through. I'm going to ask you two questions. I'll start with the first one, which kind of, draws upon a lot of the comments that have been sort of made already in terms of sort of the status of public health and the trust of public health and concerns around public health. And there is a lot of criticism that we're facing in the public health space. And the concern being, one of the concerns being that how this will potentially impact students and again, our young people to think twice about coming into public health. How do we reassure students and, sort of the best and the brightest to continue to pursue public health as an option and keep them, again, hopeful and vigilant in terms of their studies and forward leaning? So that's the first question that I'll ask.
Okay, I will. Would anyone like to tackle that one first? And while you're thinking, I mean, I think one of the things that came to mind as Beth Ann was asking the question was what I'll call you, Professor Cason, your kind of public health is a big tent comment in the sense that it's not just infectious disease. So just because you're having headwinds, maybe in one area, there are other areas where maybe there's a great amount of interest. I wonder if that's, a potential piece of the solution to that, but be curious your thoughts.
I think, and I say this partly from personal experience, that, when students, young adults are growing up, often there's a period in their life where they have reached the end of their path, whether that's the end of their undergraduate degree or the end of their graduate degree. And then they have to think, oh my gosh, what's next? And there is a significant proportion of that want to do good in the world. And I can think of no better field than public health to direct them to. Because in this field, every single moment of every single day is dedicated to making our communities and our world a better place, a healthier, happier place. So I think that's the message that we need to be communicating. And we really need to fund public health to get all those idealist jobs.
And we could just point them to Dr. Plasencia's earlier remarks. I thought that was a great encouragement to keep going.
I do want to add one thing.
Sorry, I apologize.
In answer to that question, public health deals with populations, and our response is always as a group, really, if we want to be effective. Individuals really play a small role in public health. It's the group that matters. And often that group is multiple health departments, multiple agencies, etc. Public health is a very big tent, and we welcome all. Are you an introvert or an extrovert? Doesn't matter. We need you both. Are you good at math or you can't do math? We need you. The more diverse the team, the better. And I think it's important for students to realize they have a place in public health. No matter what personality they have, what quirk you have, what medical condition you have, what impairment you think you have that can't let you work, we can use you in public health.
Thank you.
Okay, there we go. Thank you. I really appreciate that. And I think the online community appreciates that so much as well. The second question is kind of, again, a general broad question is, do you believe that reform at the state level through things like new laws, policies, et cetera, would help create a more collaborative public health scenario, particularly between reporting agencies and public health departments? It kind of goes back to some of the themes that we've been hearing about in terms of lack of coordination, et cetera. But so it's not only do you believe this reform would help, but what would that reform look like? What would those laws and policies potentially look like to help create a more collaborative, synergistic approach to public health?
Very similar to one of the questions that was on our list about whether you all see any necessary policy changes in the coming 25 years to ensure access to public health services across the state.
Can start. Okay, so something that's been requested from the veterinary community is, and again, this has to do with zoonosis as well, is just what is the level of reportability of a specific disease or condition? Because as an accredited veterinarian, we agree, okay, if we have this whole list of diseases or conditions or clinical signs, and you see it like, hey, you're going to report that. You have to report that to maintain your accreditation. And thinking about when avian influenza occurred, state by state, it was very different whether or not that was a reportable disease. So there were some that just chose 100% not to report it, even though you have all the signs consistent with the condition. So I think that in and of itself would help a ton, is just understanding like what are the rules of engagement and kind of what's the expectation once it is reported, what could or couldn't happen, because we just felt like at that time it was too many unknowns. That led to hesitancy and that led to inaction. So yes, I'm not for oh yeah, let's make some more rules, but let's just understand like what is the rule book to begin with.
Yeah, I I like what you just said. Let's not make any more rules. Rules get broken all the time. What matters is that, you have to give me a second for me to formulate this. So do the question again.
So the question was around any sort of necessary policy changes, I think, to ensure better access to public health services across the state.
So there was a word you used. You used it in a different way. I liked it. Public healthy. I think we could ask, you and I can talk and say, are you healthy? And then we can have a conversation about what that means. So we need to be able to come up with, what does it mean to be public healthy? So can you sit in a commissioner's court and stand in front of them and say, are you public healthy? That's the kind of language I think we need to use. It's not always so much about making another policy or another rule. It's about engaging the leaders in a way they can understand, in a way that they feel is personal and important to their community, and get them to define what that is. Too many times we think we can tell them what it means to be public healthy, but they have different ideas. They have different values. They come from all over the state. What may work in Lubbock, it may not work in Galveston. But it's important to use, more important than policy is getting on the same wavelength, getting the discussion going. And I think that's where we are with leaders right now. Not directing them, this is what you need to do, is actually engaging them in defining what our goals should be. And I heard someone I want to take this opportunity to put a plug in. I heard someone say long-range planning, which is my folks who used to work for me will be getting cringing, right now thinking about strategic planning because that was my big thing, right? But we tend to do that from the top down, and that's not going to work. Planning, long-term planning has to be from the bottom up. And so engaging your leaders and encouraging them to define what our goals are and how we're going to get there is going to be more productive than us insisting that this is what you need to do and these are the rules you need to put in place and these are the policies you need to adopt. But hopefully I didn't ruffle any feathers when I said that.
So I think all of the panelists here have mentioned community health workers. And that is something that I'm glad they did because I had it here and I didn't need to talk about it. But in terms of what rules could we implement, what policies could we implement, what laws can be implemented, I think there is opportunity to provide more funding mechanisms into law and policy to support the growth of that very valuable profession and public health resource. The good news is I think this is an easy sell. Community health workers are cost effective. That's been documented in peer-reviewed studies. They've also, in other peer-reviewed studies, have shown positive return on investment. I think it's an easy sell. But right now, as a profession, they don't have a lot of funding mechanisms built into law. And I think that that's a real opportunity to support the development of that public health resource. I also want to do a plug for a different type of surveillance. Policy surveillance. We live in a country that is built on this idea that each local jurisdiction and state jurisdictions is free to experiment with policy innovations. The problem is in this country, we don't measure the results of those policy experiments. We don't know the outcomes of what works and what doesn't from a policy perspective. And we don't have that data to understand if I do this, then this will happen. Or if I do this, then this will probably happen. Then we can't have that conversation with our policymakers. We can't say, well, listen, if this is something that you care about, then this is the type of policy that we need to implement. Because those states, those local jurisdictions that do this get the outcome that you want. But to do that, we need to do policy surveillance. We need to accurately measure law and policy as an exposure variable as structural determinants of health. So.
Dr. Wells, did you have anything to add to that?
Yeah, I mean, I think the other thing is we need a vision for what public health should look like kind of in 25 years or 20 years. We don't have even a simple document on what governmental public health or public health systems could be in Texas. I think we don't have a way to show collectively to policymakers what we're wanting to do with our public health system. So I think this is an opportunity as we're kind of seeing the destruction or dismantling of public health systems is what does it look like to rebuild those and put really smart people from, local areas and state areas to really, think through what that could be.
Well, I think we're about to get the hook. So before I bring everything in to a close, I wonder if anyone has any last thoughts or burning comments before the end. I thought it was really informative.
No.
No. You don't get the hook. Okay.
I know all of you are here because you're really passionate about what you do. So keep that fire burning, whatever it takes, even when you're in a bad place, a difficult time, there's colleagues that have your back. So don't ever forget that.
Let's give the panel a round of applause. Thanks.
Oh,
Thank you, Ms. Deegan and panelists, for such a candid and timely conversation. Let's give them all just one more round of applause. Now, before Dr. Borwinkle brings this year's summit to a close, just a quick reminder to you all. Please be sure to complete the event survey. Completing the survey is the only way to receive your continuing education credit, as well as provide your feedback on how we did, so that hopefully if we're able to have a summit next year, we can take that and feedback and incorporate it into our planning. We will bring a QR code up at the conclusion of Dr. Boywinkle's remarks. And if any have to run out the door and don't have time to sit to take the survey, we will have some of our TEPHI folks distributing little slips of paper that have the QR code on there. So you can kind of take the survey at your leisure. Please note though, once you submit the survey, it'll take about 30 minutes for you to receive your CE certification. So bear with us. If you don't get it, say within an hour, then email us and reach out to us for that certificate. Now to officially close out the summit, I'd like to introduce Dr. Eric Borwinkle. And Dr. Borwinkle is Dean and M. David Lowe Chair of Public Health at the UTHealth Houston School of Public Health, a role he has held since 2015. Under his leadership, the school's faculty, education, and research programs have continued to grow, with an emphasis on applying academic expertise directly to community needs. Beginning in February 2020, he met daily with Texas Medical Center leadership, local health authorities, and community leaders to coordinate strategies, share best practices, align roles and messaging, and provide collegial and personal support throughout the public health emergency. This spirit of cooperation became a cornerstone for our shared commitment to the health of all Texans, which is captured in this Public Health Summit, and ongoing activities to address other public health needs such as chronic disease, children's health, and mental health. It is my pleasure with that to welcome him to the podium for a few closing remarks.
Thank you very much. It's been a long day. I'm going to be very brief. All important things are written on a napkin. Okay. The first thing I want to say is ask all of the speakers and attendees to put their hands together and thank the staff who've helped get this together. We very much appreciate all of your hard work and your help. In trying to think about what to say to close off, I really want to focus on one comment that Dr. Martinez brought up, one word, and it's been used almost in every panel, and talk a little bit about collaboration. And I'm not going to sugarcoat collaboration. Collaboration is tough. Humans are a very tribal group. We tend to focus on collaboration with the person sitting next to us, with our kids, with our colleague, with our boss. Collaborating with the folks on the other side of the river, oh my God. You have to be pushed to do it. So the first comment I want to make, you don't generally collaborate because you think it's a good idea. You collaborate because you have to. You have to collaborate. And I really think the field right now is stressed. That's been brought up over and over again. And there's a tendency when a field is stressed, when you're stressed, is actually to circle the wagons. And I think in order for us to get out of this, and like I said, I'm not going to sugarcoat this. I think it's going to get a little bit worse before it gets better. And so really, the time for us to collaborate is now. In order for us really to pull this field forward, which we all have the passion and the ability to do, we're going to have to pull the field forward together. We're going to have to collaborate and work together to pull the field forward. Because if we find out, you know, we're sort of not, we're kind of picking on each other, or we're not collaborating, we're not going to pull this field forward in a timely manner. And the timely manner is important because we need to bring young people into the field. You heard that in the questions. And we're all very positive about the field, and we should be positive. I'm also positive. But we need to pull the field forward and open it up in a timely manner. So these people, you know, new young people, new bright young people will bring their talent into the field. And we're going to do that together by collaborating. And then my final comment is, again, when resources get tight, money gets tight, jobs get tight, again, we tend to circle the wagons and try to keep the money within the family. You know, royal families had that worked out. We only married our cousins like for thousands of years. And if you can go to museums and see the effect of that. It's not very good. And so we need to collaborate to be competitive financially. I don't know as much, particularly on the state level. But I do know in my world, bringing monies in from various sources is a competitive business. And we shouldn't be competing with one another. We should be collaborating to bring resources in to benefit the work we're trying to do to help communities, to also be able to hire new, young, talented people, again, to pull the field forward. So I really appreciate all of you coming here today. I think we have built a spirit of collaboration throughout the day, but I do ask that we carry it forward because, again, it's not second nature. We're going to have to work to collaborate. And we have to, like I said, we have to collaborate for the good of the field. And I look forward to collaborate with each and every one of you. And I'll also look forward to seeing you next year. This is a great meeting on a timely topic that every year we drill down on. And so again, I thank all of you for coming, and safe travels home, and take care. Thank you. I think we're adjourned.
We are adjourned. I was just gonna say, I couldn't say it better than that. Here is your QR code for the survey. Again, if you need to try to beat traffic, we've got some of our TEPHI folks at the back of the room that you can take a slip with you with the same information. Note to those online, your access code is a little bit different. It's got a V for virtual in there. So thank you all again for joining us today, and safe travels home.